Now we're going to see thyroiditis. Thyroiditis could be painful and non-painful. Painful and non-painful. In painful thyroiditis, we have Decker veins thyroiditis, and auto-infectious thyroiditis. In non-painful, we have Riedel thyroiditis and Hashimoto thyroiditis. We can divide it like this, or we can divide it as thyroiditis that mainly produce hypothyroidism or that mainly produce hyperthyroidism. So the ones that produce hypothyroidism will be Hashimoto, unless we were talking about the postpartum thyroiditis of Hashimoto that we'll talk it in a second. The Riedel also produces hypothyroidism, and the ones that produce hyperthyroidism would be Decker vein. Decker vein produces hyperthyroidism, usually. There could be exceptions, like could present with hyperthyroidism followed by hypothyroidism, etc. So, just very quickly review of each one of them, because we'll talk about them in other videos. Decker vein thyroiditis is a viral thyroiditis that presents with extremely tenderness in the physical examination. The histological examination will be a granulomatous pattern due to infiltration of macrophages. Sometimes we can see the beginning that is the infiltration of neutrophils with microabscesses, but we usually go see only the macrophages, the granuloma. The patient will present with hyperthyroidism due to increased secretion of T4 and T3. This is a increased secretion that is just the viral cells that are being destroyed are releasing T4 and T3, and for that the patient has hyperthyroidism, but because the hyperthyroidism there will be suppression of TSH, and so the synthesis will be inhibited, the synthesis of thyroid hormone, and so the patient will have a low radioactive iodine uptake because the synthesis is inhibited. The treatment is propranolol in order to inhibit the adrenergic effect of the thyroid hormone. The patient will present in the labs with increase in the erythrocyte sedimentation rate, increase C-reactive protein, and other acute phase reactants. The pain can be referred to the jaw or to the shoulder or arm. The autoinfections thyroiditis present with a normal thyroid function test and sometimes hemorrhage. Now the non-painfuls would be Riedel, that is a fibrous replacement, fibrosis and inflammation of the thyroid gland that can present with compression signs like dyspnea, hoarseness, etc. It will be seen in 40 years age, this is in order to not to confuse them with anaplastic carcinoma, and this is associated with other autoimmune diseases that are associated to IgG4. This is fibrosis of the retroperitoneum or mediastinum, inflammatory aortitis, and autoimmune pancreatitis. The autoimmune pancreatitis, remember, that is that is responsive to steroids. Now, Hashimoto's thyroiditis. Hashimoto's thyroiditis is a autoimmune disease that is associated with the HLA-DR3 or DR5, present with germinal centers and lymphocytic infiltration. Also, this is called chronic lymphocytic thyroiditis, and we will have increased risk of B-cell lymphoma due to the marginal zone because of the increase in germinal centers. This is the most common cause of hypothyroidism in patients with sufficient iodine. There will be thyroglobulin antibodies and anti-peroxidase antibodies. The patient can have hyperthyroidism at the beginning, but usually we will see them only in hypothyroidism. so the T4 and the T3 will be low, and the TSH will be high. The diagnosis is just finding a non-tender goiter, that is certainly with the labs or after the labs. The treatment is just giving levothyroxine, and there is this subtype of postpartum thyroiditis or lymphocytic thyroiditis or silent thyroiditis, that is leaking of the T4 and T3, that is just leaking, and this leads to hyperthyroidism. This hyperthyroidism will suppress TSH, and this will suppress the synthesis of T4 and T3, so again the radioactive iodine uptake will be low. And the treatment will be propranolol again. Here, sometimes the patient can present with hypothyroidism or hyperthyroidism followed by hypothyroidism, but the most common will be hyperthyroidism. This also would have lymphocytic infiltration and occasionally germinal centers. This Decker vein and postpartum thyroiditis present in similar way, except the tenderness, and there is no inflammation here, there is no erythrocyte sedimentation rate increase. So for Hashimoto and Riedels, we give T4 because usually they present with hypothyroidism. Unless we postpartum, we give propranolol, and for the veins, we give propranolol also. And to manage the pain, NSAIDs like aspirin or prednisone.